Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Rotator Cuff Repair Advances in Treatment Options, presented by Dr. John Costouros, orthopedic surgeon with the Institute for Joint Restoration and Research at Washington Hospital Healthcare System. Dr. Costouros is a shoulder specialist serving patients in the Bay Area and beyond. Dr. Costouros has excelled in his field by providing the very latest advances in the diagnosis and treatment of shoulder disorders. He completed his fellowship at Harvard Medical School of Shoulder and Elbow Surgery and is board certified with the American Board of Orthopedic Sports Medicine and the American Board of Orthopedic Surgery. Please welcome Dr. Costouros.
Thank you. Good morning and welcome, everyone. I'm honored and excited to spend the next 30 minutes or so talking to you about a topic very near and dear to me, rotator cuff injuries and their latest treatments. So my journey into shoulder surgery began early on. My own sporting activities as a high schooler nearby at Bellarmine Prep in San Jose with water polo and swimming kind of embarked me on some understanding of shoulders as I developed my own injuries over time. I completed my undergraduate work at Stanford University and then medical school and fellowship up the peninsula at UC San Francisco. As Christy mentioned, I did the first of two fellowships, the first at Harvard in shoulder and elbow surgery, the second in Zurich, Switzerland, where I learned about some innovative techniques that weren't yet available in the United States, and then began my career at Kaiser and spent most of my career at Stanford University as part of the full-time faculty, training many residents and fellows over a decade. And then I returned back to join Dr. Dearborn in late 2019. It's been an honor and a pleasure. We both share similar philosophies, and it's been excellent synergy so far. So I've spent my entire career exclusively focused on shoulder disorders. And this is Dr. Codman, who is really the godfather of shoulder surgery, who spent his early career at Massachusetts General Hospital in Boston. Rotator cuff tears, which is the most common problem a shoulder specialist will see, is what we're going to talk about today. Sports disorders, instability problems such as dislocations, fractures of the shoulder and the collarbone are things I treat. Arthritis, just like in hips and knees and other areas, certainly affects the shoulder as well. And so there are joint replacements, which I specialize in. And then, unfortunately, sometimes I'm referred patients who have had failed prior surgeries, so revision problems. And we can address many problems with arthroscopic or minimally invasive technique, but sometimes open surgery is really the way to go, even in 2022. So here we go. So in terms of treatment, sometimes the best treatment is really doing therapy, maybe some injections. We have some biologic therapies, which are injectables, such as stem cells and PRP, platelet-rich plasma, which is newly available, but still under some investigation. As you see to the upper right, arthroscopic images of patients with a rotator cuff tear and undergoing arthroscopic rotator cuff repair. Here's the tendon edge here, which the cursor is pointing to. And then sometimes we get into other treatments. Here is a tendon transfer. So this is the latissimus muscle, and so we transfer this over into the shoulder to make up for a tendon tear which was not repairable. So in some patients, this is a preferred treatment. To the lower left, this is what a reverse total shoulder looks like. This is something I'm very proud to have brought to California in 2004 from Europe, where it was available sooner and only FDA approved in the United States in 2004, and it has become a godsend to people with certain complicated shoulder problems. To the right here, where it says balloon placement, this is some new technology which was only made available last summer. I was one of the first surgeons that was offered this technology, and so sometimes putting this balloon in the area above the rotator cuff is a good salvage procedure if not repairable. And then finally, here's an example of using a graft of tissue. This is cadaver tissue, and this is called SCR, or superior capsular reconstruction, again, another technique. So there's lots of different things that we can offer patients with rotator cuff problems. Now, why am I so interested in the shoulder? Well, the shoulder is the most complicated joint in the entire body. It has the widest range of motion. It has very intricate anatomy. It has bones and ligaments and tendons and capsule. We're going to talk a little bit about all these things, but these elements create a delicate balance and a symphony, if you will, that allow us to have such a wide range of motion. And so as we go from superficial to deep into the shoulder, this depicts the capsule here. And all joints are enclosed with a capsule which contains joint fluid which lubricates the surfaces. And as we go even deeper, these are ligaments which are the various bright colors as you see there. And then the socket of the shoulder joint, which is called the glenoid, is also depicted here. And it's very small, like a golf tee, compared to the ball of the shoulder joint, which is the humerus or humeral head and the golf ball. Now, rotator cuff tears affect 50% of the population aged older than the age of 60. As I said, it's the most common problem someone with shoulder pain is going to have when they present to me. It accounts for $3 to $5 billion per year in medical cost and decreased productivity, and it has a significant impact on overall function, quality of life, ability to sleep, and things that we do on a very daily basis. It's the most common thing that I see. Now, what is the rotator cuff? Well, the rotator cuff is comprised of 4 tendons. Tendons attach muscle to bone throughout the entire body. And the 4 muscle tendon units are listed here. These are called the supraspinatus. That's the muscle that gives you power raising your arm overhead like this. Infraspinatus, which is one that gives you power externally rotating. Teres minor, which is another more minor external rotator. And then the subscapularis is the rotator cuff muscle and tendon, which is kind of depicted right here, which is responsible for internal rotation. So it's kind of like a swim cap that encloses the head of the humerus, and that's what the rotator cuff is all about. What's the function of the rotator cuff? It provides strength for arm rotation and elevation, as I mentioned, internal and external rotation, strength overhead, and it stabilizes the shoulder joint. So all these functions that you see here, the rotator cuff is responsible for. How does the rotator cuff get injured? Well, just with everything, wear and tear as we get older, loss of blood flow, compression or friction. So there's a bone that lives above the rotator cuff here, which is called the acromion, and so the tendons can pinch against that, and bone spurs can develop, which can accelerate tearing. Repetitive wear and tear with work, with sport, can accelerate tendon degeneration, and sometimes it's a single fall onto your outstretched arm, a car accident, and these kinds of things can cause degeneration. And we see a whole spectrum of injuries. Sometimes it's just inflammation and bruising. That's usually temporary. Sometimes there's impingement, as I talked about earlier, compression onto the tendon. Sometimes the tearing can be partial, and sometimes it's a full tear. And so these are the spectrum of things that we see with rotator cuff disease. Now, what's unique about the rotator cuff? We, as humans, have the ability to heal many things. We have cuts that can heal, we have broken bones that can heal, but the rotator cuff tendons are very unique. Once they're partially torn or fully torn, they can never heal back. The tissue remains torn. The symptoms can get better, so some people who have partial tears or full tears that don't heal, pain can reverse itself, function can get nearly back to normal, and they may not even know that they have these tears. So the symptoms can improve, and sometimes they don't. And one of the things that's unique about full thickness tears of the rotator cuff tendons is once they're torn all the way through, the muscle and the tendon degenerate over time, and they go through a process that's called fatty infiltration. And so this is an arthroscopic picture of what a torn rotator cuff tendon looks like. It should be attached down to the bone below. This is what an MRI looks like. MRI stands for magnetic resonance image. It's something we've all heard about. It's a very detailed diagnostic imaging study. We use it in shoulders all the time. And what this shows here, here's a muscle of the supraspinatus that has been torn. The white part is fat. The blackish part, which looks circular below, is the muscle. And over 2 years, you can see just progression of the whiteness or the fat. That's what fatty infiltration looks like. And when it gets too far along, you just can't fix the tear. And these things correlate with function, with pain, and what we can do surgically if needed. And eventually, they just can't be repaired. And that's a bad situation, but there are options available. And this is just looking under the microscope what a normal muscle looks like to the left, all that nice red material, and to the right with all the white in between. So how do we evaluate the shoulder? Well, we begin with talking to you all about what's been bothering you. We call that the history. And then we start moving the shoulder around and testing things. That's called the physical exam. And then we obtain imaging such as x-rays or MRI or other studies. And then we explore what to do. So patients with rotator cuff impingement and rotator cuff disease really have pain in the shoulder and upper arm here. It can radiate down to the elbow, not past the elbow typically. It's worse with overhead motion, reach behind your back, across your body. I mean, think about all the things you do on a daily basis which can aggravate these kinds of symptoms. Rotator cuff disease is classic for pain at night, and it's something to do with position at night or maybe not being aware of what you're doing when you're sleeping. It can be very, very painful. And so for many problems, we can start with physical therapy, anti-inflammatories such as ibuprofen or Advil. In some cases, we inject steroid or other agents into the shoulder, and then ultimately surgery if none of these things work. Now, in the old days, shoulder surgery was very painful, and we had big incisions, big exposures. We would split through muscle. We don't do that anymore, but you can imagine why. You may have heard from patients that shoulder surgery is very, very painful. But then came along arthroscopic technique, which is minimally invasive, small incisions. We use cameras and lasers and other devices to kind of do work, and then these are the incisions now for much of what we can do. Here's a video of what a rotator cuff tear looks like, and so I'm kind of pulling on it, and this is what an anchor looks like, which is what we put into the bone with sutures attached to bring the tissue back to where it tore from, and I'm going to accelerate a little bit. These are the sutures. Now we're using these devices to pass through the tendon edge, put in another anchor, and then we tie everything down, and then at the end result is something such as this. Everything's kind of back to normal. And this is the beginning of the recovery. So rotator cuff repair is about a 40-minute procedure, excellent results. There is an inconvenience with use of a sling afterwards for about 4 to 6 weeks. Physical therapy is very critical, and then it takes about 3 to 6 months to recover. So that's plan A, if we can fix things. What about if we need to go to plan B or C if it's not repairable? And so we can just do other things in the shoulder to help with pain, but leave the tendon tear alone. That's called a debridement. The biceps tendon in the front of the shoulder can be treated, which is a frequent pain generator. Maybe we just do a partial repair. Maybe we do tendon transfers like the latissimus transfer I talked about earlier. And then there's a whole slew of other things. This is the superior capsular reconstruction, where we use a graft of cadaver tissue to bridge the gap. And then there is this balloon that we talked about earlier, which is new to the scene. Reverse replacement, as we see here, and then other things. So what's latissimus dorsi transfer? So some patients who have irreparable tears, and that's what it looks like at surgery, can have their latissimus muscle, which is something that you can easily transfer and use for the shoulder without having a consequence to the native function of the latissimus. And as you can see here, we sling it under the back part of the shoulder and then over the top of the shoulder joint, and then we do a repair. And so as you can imagine, it's a big procedure. But here's a patient of mine from years ago. So that's what he could do before surgery. So that's a guy that had a latissimus dorsi transfer. He did well. He was a younger guy, didn't have a lot of arthritis, so we didn't do something like a shoulder replacement at the time. So there's that big incision from the latissimus transfer, but he was happy with his outcome. But that's a big procedure, and that took for many patients a year, if not longer, to recover. So there have been other development of other procedures, such as this one. So this is arthroscopic superior capsular reconstruction. This had its advent in Japan in 2011. And I had the privilege of being an invited professor to spend several months in Japan and exchange information. And so in the midst of my visit, learned about this and brought it back to the United States and to Stanford at the time. And so it's basically using cadaver tissue to bridge the gap. And so here's the graft of tissue, which we kind of can slip into the shoulder through these portals. We anchor it down, and so this is a patient that did well with that procedure. Now, what about more complex procedures where there's arthritis with rotator cuff imbalance? And so as you can see here, the head of the humerus will start to shift up, erode bones, and accelerate arthritis. So this is the reverse shoulder replacement, FDA approved in 2004. I have tremendous experience designing this implant and improvements of this implant over the past 20 years, and it makes up a big part of my practice. This is a patient of mine on the front page of the Chronicle who had joint replacement and was featured and did well. Here's some x-rays of a patient with arthritis with irreparable rotator cuff tears from 2005. I had the privilege of seeing this patient 17 years after surgery doing well, and this is what he looks like. So today we have even more technology that's coming down the pipeline. We have software which allows us to virtually plan surgery. We have intraoperative guidance and tools where we can execute the preoperative plan with precision. And a lot of these replacements, if not most, are done in an outpatient setting today. And we have bone-preserving stemless implants, which we have, and I was one of the first to have an FDA trial here at Washington, which we recently completed for a reverse replacement, which is stemless or bone-preserving. It looks like this. So there's no stem going down the humerus. It's a stemless device, less pain, faster recovery. And so these are examples of kind of the software that we can use. And then goggles that you can wear. Here's a fellow that I trained years ago that allows you during surgery to have guidance. And so here's a representative patient who had a reverse. What's the future hold? Well, robotic assistance, tissue engineering, understanding growth factors a little bit better, and then augmented and virtual reality. So in conclusion, most rotator cuff tears can be treated by conventional arthroscopic methods and yield excellent and durable results. There are salvage procedures which can be considered, but irreparable tears require proper patient selection. And I think the future of rotator cuff repair lies in the enhancement of biologic healing. Thank you very much for your attention, and I'm happy to take any questions.
Thank you. We do have a couple of questions. If I have shoulder pain, at what point should I see an orthopedic specialist?
Well, I think shoulder problems are so common. It's always a good idea to get seen by somebody if it lingers. So if you have pain that is persistent after a couple of days or a week, or if you have weakness or you've had a recent fall or a trauma, it's better to get in to see a specialist sooner than later. I would present this with your primary care doctor as well on the earlier side. Sometimes fractures can be missed or other injuries which can go ignored for an unnecessary period of time. And because timing is so important with rotator cuff tears and it's such a common problem, better to be safe than sorry. So see someone on the sooner side.
Perfect, thank you. Another question is there any way to prevent these rotator cuff injuries by exercise or any other means?
Well, I use the analogy of the rotator cuff being a little bit like tires on a car. So the more miles we drive, the more we use our arms with life. And you can't eliminate all the things that we use our shoulders and arms for. So part of it is just what it's going to be with time. Obviously, big traumas, if they can be avoided, are better. And sometimes it's just wear and tear. So things that we know are very bad for tendons in the shoulder are things like smoking. So believe it or not, smoking is not just bad for the lungs, it's very bad for the homeostasis of rotator cuff tendon tissue and healing after rotator cuff repairs, for example. So that's one thing that can be avoided. The other thing is just moderation. So don't just do the same thing over and over and over again. Let's say you're obsessed with just doing push-ups all day long. That's obviously not going to be good for the shoulder. Cross-train, make sure your technique is appropriate, and then do different things to mix things up.
Great. And then our last question is, what is the recovery time with a shoulder replacement?
So remarkably, even though shoulder replacement surgery appears to be a more invasive or open procedure, people find that the recovery is easier than some of the less invasive arthroscopic techniques. So typically patients go home the same day. They're in a sling for about 3 or 4 weeks. They can move their elbows, their wrist, and their hand right away. Sling comes off at about 3 to 4 weeks. And then the recovery and the therapy goes on for about 3 months. So typically it's about 3 to 4 months to get, on average, about 80% of your ultimate outcome. And then the next 20% to get to 100% can take another 2 or 3 months after that.
Okay, thank you. And this does conclude our program. Thank you, Dr. Custeros, for this insightful presentation. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.